you might know estrogen as a reproductive hormone. That's the classic definition.
Yeah, that is definitely how it's usually categorized.
But today we're going to show you why it is actually, well, it's the master architect of your skin's repair system.
Right. It's doing so much more than people realize.
Exactly. So welcome to the deep dive. Our mission today is to explore this really profound biological shift. We're looking at how declining estrogen, whether that is through natural aging or sudden surgical menopause, how it fundamentally rewires your skin's ability to heal.
And it is a massive rewiring.
Yeah. We're talking about why losing it changes everything from how a deep surgical scar sets to, like, where you should actually be applying your daily medications.
It's a biological reality that governs how we recover from major trauma. Yet it rarely gets the spotlight it deserves. I mean, when we look at a wound failing to close or a surgical site reopening, we tend to look at the surgical technique, right?
Right, or the post-op care.
Exactly. The bandages, the creams.
Yeah.
We rarely look at the foundational hormone that's dictating the behavior of the skin cells themselves.
And to get to the bottom of how this works, we've got a really robust stack of sources for you today. We are pulling from clinical dermatology literature, in-depth studies on vaginal wound healing post-surgery, cutting-edge research on inflammatory proteins.
Like the macrophage migration inhibitory factor, which is fascinating.
We will definitely get into that one. And to see how all this plays out in everyday life, we're even pulling from a Reddit thread discussing the intersection of transdermal hormone therapy and heavy tattoos.
I love that we included that thread. It's the perfect cross-section of, high-level histology and everyday patient experience.
Yeah, it grounds it.
Because to really understand why surgical incision struggles to close or why a scrape takes a month to fade, we have to establish the baseline.
Right, what's happening normally.
Exactly. We need to look at what estrogen is doing for healthy skin every single day before the trauma even occurs.
So let's establish that baseline. In a healthy system, the sources say estrogen is regulating dermal and follicular homeostasis.
Right, maintaining the balance.
So it's essentially acting as the general contractor on a bustling construction site. The contractor is handing out the blueprints, maintaining the environment, keeping all the workers, producing high-quality materials on schedule.
That contractor analogy maps perfectly onto the cellular mechanics. Estrogen manages this site by binding directly to specific receptors, ER-alpha and ER-beta.
And those are like docking stations.
Yes, exactly like docking stations embedded throughout your skin. You find them in keratinocytes, which are the primary cells forming your outermost layer, the epidermis.
Okay, the surface layer.
Right. And you also find them deep down in the dermal fibroblasts, the cells responsible for building the structural scaffolding of your skin.
So when estrogen docks at those stations, it basically signals the fibroblasts to start manufacturing.
It puts them to work.
Right. It tells the body to produce collagen, specifically types I and III, which give the skin its tensile strength.
That's the firmness.
Yeah. And it triggers the production of elastin for flexibility. Plus, it ramps up the manufacturing of hyaluronic acid and ceramides,
Which are crucial lipid molecules that hold on to moisture. So long as the contractor is on site, the materials arrive on time.
But when estrogen levels drop,
The structural integrity of the skin plummets at a startling rate. I mean, clinical studies show that women can lose up to 30% of their dermal collagen within just the first 5 years of menopause.
wait, 30%
Yeah.
in 5 years?
Yes. The scaffolding is literally disappearing.
Wow. So the workers on the construction site don't necessarily stop, but without the contractor, they become what? Sluggish?
Sluggish, disorganized.
Yeah.
And the building materials become brittle. The immediate functional consequence of losing that organization is severe.
What happens?
Well, when ceramides and hyaluronic acid aren't being synthesized and arranged efficiently, the skin's barrier function breaks down. This leads to a phenomenon called transepidermal water loss, or TEWL.
TEWL, right. We see that term constantly in the dermatology literature. It's everywhere. Because without that tightly packed lipid barrier sealing the surface, the moisture inside the skin literally
That evaporates. It just evaporates into the air.
That's wild.
And it is a two-way street. While water is escaping, environmental irritants and pathogens are easily entering.
So if you are listening to this and wondering why mature skin feels fundamentally different, this is why.
Exactly. Even before a cut or an injury ever happens, the tissue is instantly more fragile, dry, and structurally compromised just from the hormonal shift alone.
Which brings us to the core of our deep dive today. We know the building is fundamentally weaker. What happens when that compromised building sustains major damage?
Right, the actual trauma.
Yeah. When this low estrogen skin is sliced open by a scalpel or injured in a deep fall, the body initiates the four main phases of wound healing.
But looking at the clinical data, the entire biological cascade seems to, well, misfire from the very first second.
It's a cascading failure of biological logistics. Let's trace that real-time response, starting with phase 1, hemostasis, the clotting phase.
The immediate goal of hemostasis is just to stop the bleeding. The blood vessels are damaged, the endothelial lining is breached, and the body desperately needs to seal the leak.
And to build that seal, your body sends circulating platelets to the site of the injury.
Right. But platelets don't just magically stick to empty space.
They need something to grab onto.
Exactly. They have specific glycoprotein receptors that are designed to bind directly to the exposed collagen in the damaged tissue.
Okay, so they anchor themselves to the collagen fibers and then stick to each other to form a physical plug.
But we just established that low estrogen skin has lost up to 30% of its dermal collagen.
Oh. The structural anchors are missing?
Missing or severely depleted, which means the platelets arrive at the emergency, but there's simply less surface area for them to grab onto.
So they literally slip.
They do. The plug that eventually forms is imperfect and structurally weak, which delays the entire coagulation process. The body takes significantly longer just to stop the bleeding and seal the initial breach.
And a delayed seal means the wound is open to the environment longer.
Yes.
Which pushes us into phase 2, the inflammation phase. And this is where the literature really starts flashing red warning lights.
Big time. In a hormone-rich environment, estrogen naturally dampens the early inflammatory cascade.
It keeps things calm.
Right. It prevents the body's immune alarm from ringing too loudly. But without estrogen's moderating influence, the body's immune response severely overreacts.
It floods the area.
Yes, with pro-inflammatory cytokines, specifically molecules like TNF-alpha, which acts like a chemical flare gun calling in more and more inflammation.
And a critical protein called macrophage migration inhibitory factor, or MIF. The sources show that elevated levels of MIF lead to markedly delayed wound healing.
It stalls the whole process.
But I have to push back on the premise here for a second. If I suffer a deep laceration, isn't inflammation a necessary biological response?
It is.
I mean, the body sends in the inflammatory cavalry specifically to kill off any bacteria that entered the open wound. We want that, don't we?
We want an acute response, yes. A quick targeted inflammatory strike is essential to clear cellular debris and neutralize pathogens. But the danger lies in the transition from acute to chronic inflammation.
So what breaks down in that transition when estrogen is missing?
Well, under normal conditions, immune cells called monocytes travel through your bloodstream to the wound. Once they arrive, they need a chemical signal to transform or differentiate into tissue-resident macrophages.
And those macrophages are the cleanup crew, right?
Exactly. They eat the dead cells and set the stage for new tissue to grow. Estrogen plays a huge role in facilitating that transformation.
So without it?
Without it, the monocytes get stuck in a transitional, angry state.
They never fully become the cleanup crew?
No. Instead, they just sit in the wound bed and pump out an excess of tissue-degrading enzymes called matrix metalloproteinases.
Matrix metalloproteinases. That sounds destructive.
It is. They're literally chewing up the cellular matrix. They dissolve the healthy tissue that the body is desperately trying to build.
Oh, wow.
So the inflammation lingers for weeks. Instead of a quick bacterial strike, it turns into a prolonged siege where the body is essentially attacking its own repair job.
That's awful. And to compound that problem, despite this massive lingering inflammatory response, the actual defense against infection is crippled.
Yeah, that's the irony of it.
Estrogen normally fuels something called neutrophil oxidative metabolism.
And that mechanism is fascinating. Neutrophils are a type of white blood cell that act as first responders.
Right.
When they encounter bacteria, they engulf it, a process called phagocytosis. But to actually kill the bacteria once it is engulfed, the neutrophil uses an oxidative burst.
It releases reactive oxygen species.
Exactly, which is chemically akin to microscopic bleach to basically melt the pathogen.
And the clinical data indicates that estrogen is the fuel for that chemical bleach production.
It is. And estrogen deficiency means those neutrophils lose their phagocytic capacity. They lose the metabolic fuel required to deploy that oxidative burst.
So they can swallow the bacteria but can't kill it.
Precisely. So you are left with a drastically increased risk of the wound becoming infected, all while the surrounding tissue is being degraded by chronic inflammation.
It is a brutal cascade. The platelets can't anchor to form a clot, the monocytes get stuck and destroy healthy scaffolding, and the white blood cells lose their ability to neutralize bacteria.
It paints a very clear picture of why declining estrogen is a massive variable in recovery.
Which brings us to the ultimate stress test for this compromised biology: major surgical intervention. Because this biological reality isn't just an issue for scraped knees, right?
No, it dictates the success or failure of complex operations.
Let's focus on surgical menopause. Unlike natural menopause, which is, a gradual tapering of hormone production over several years.
Surgical menopause usually occurs via a bilateral oophorectomy, the removal of both ovaries.
Right, so the hormonal shift isn't a gradual powering down of the factor.
No, it is someone walking in and ripping the main breaker switch completely out of the wall.
That abrupt, immediate drop in systemic estrogen is tied to severe healing delays. And the sources specifically highlight how this impacts vaginal surgeries.
Most notably, pelvic organ prolapse, or POP surgeries, which often occur around the same time as ovary removal.
Pelvic organ prolapse is a condition where the structural support of the pelvic floor weakens, right?
Right, allowing pelvic organs to drop out of their normal positions. To fix this, surgeons have to reconstruct the support system.
And for a POP surgery to be successful, the patient requires incredibly strong tissue healing to hold the organs back in place.
Exactly. If the tissue doesn't heal with enough tensile strength, if that collagen isn't thick and robust, the organs will simply prolapse again.
And the failure rate in the literature is staggering.
It's really high.
Recurrence happens in up to 50% of cases. Half the time, the patient's internal repair simply cannot hold the load.
Because the contractor is missing from the surgical site. The fibroblasts cannot produce the type I collagen needed for tensile strength.
But the literature suggests a highly effective intervention. I read that applying topical estrogen therapy directly to the surgical site accelerates macroscopic wound closure.
It does.
It promotes neovascularization, which is the building of new blood vessels to supply oxygen to the wound.
And it significantly drops the levels of that inflammatory flare gun molecule we mentioned earlier, TGF-beta 1.
So topical estrogen certainly triggers all of those positive mechanisms. But diving deeper into the research introduces what clinical investigators call the dual-edged sword paradox of hormone application.
Yeah, the Roberta study on this paradox is incredible.
Walk us through what they found.
So the researchers looked closely at the application of postoperative vaginal estrogen, meaning they waited until the surgery was finished and the tissue was wounded to apply the hormone.
Okay, after the fact.
Right. They found that throwing estrogen at the wound immediately after surgery rapidly heals the surface layer of the tissue, the epithelial layer.
So the barrier function improves almost instantly.
It does. But it triggers an opposing reaction underneath.
The paradox.
Yes. In the acute healing phase, postoperative estrogen actually decreased the collagen content and the overall stiffness in the deeper stromal compartment.
Just so we have our terms straight, the epithelial layer is the surface skin, and the stromal compartment is the deeper structural scaffolding.
Right. It's the load-bearing tissue. The stroma is where the actual physical strength of the repair lives.
So using our construction analogy again, it sounds like prioritizing building a beautiful, perfectly waterproof roof on a house while the concrete foundation underneath is still wet, weak, and settling.
That's exactly it. The surface looks fully healed to the naked eye, but the structural support holding the whole thing up is severely compromised,
The internal load-bearing wall is just too weak to hold the organs.
leading right back to that 50% recurrence rate.
Which highlights a really crucial takeaway regarding clinical intervention. Treating menopausal wounds isn't just about throwing hormones at the problem to see what sticks.
Not at all. The timing of the treatment dictates whether you are helping the tissue heal or accidentally weakening its structural support.
And the current clinical guidance is shifting to reflect that. The data leans heavily toward preoperative estrogen therapy.
Yes, you apply the topical estrogen for weeks or months before the surgery. You build up the collagen reserves.
You thicken the stromal compartment.
Exactly. You improve the baseline tissue strength before the scalpel ever touches the skin. You don't try to hire the general contractor while the building is actively on fire. You get them on site months in advance to fireproof the walls.
It is a profound shift in how we approach surgical preparation. Now, if preoperative topical estrogen is becoming the gold standard for strengthening compromised skin, we have to look at the delivery mechanism itself.
Right, how the body actually takes it in.
Yeah. How does the body absorb these hormones through the skin? And what happens when the patient has intentionally altered that dermal landscape?
This is where we transition from the surgical suite to the everyday application of these therapies. The sources include a really revealing Reddit thread that highlights a massive blind spot in transdermal medicine.
Yeah, a user on the forum is asking a very practical question. She has been prescribed estrogel, which is a systemic transdermal hormone therapy you rub to your arm or leg daily.
And the body absorbs it through the skin and distributes it into the bloodstream.
Her question is whether she can apply her daily gel over an arm that is heavily covered in tattoos.
And the official medical guidance strictly advises against it. Patients are instructed to find a clear patch of skin, completely free of ink, to apply any transdermal hormone therapy.
And the users in the thread start speculating about why this is. One of the top comments suggests that the issue is similar to how dark tattoos confuse fitness watches.
Oh, right.
You know, a heavy black sleeve blocks the green optical sensor on the back of a smartwatch from reading your heart rate. The user wondered if the dark ink is just confusing the gel, but that is a complete misunderstanding of the mechanism, isn't it?
It is a logical guess based on everyday technology, but the biology is entirely different.
How so?
Well, a fitness watch relies on light. It shines an optical light through the skin to measure the expansion and contraction of capillaries. Dense tattoo ink physically absorbs that light, preventing the sensor from getting a reading.
But transdermal estrogen doesn't rely on optical sensors.
No, it relies on chemical absorption. The gel relies on a highly organized lipid matrix. When you rub the gel on healthy skin, the hormone molecules have to diffuse through the tightly packed lipid layers of the epidermis, sink down into the dermis, and eventually reach the capillary beds to be swept into the bloodstream.
And where exactly is tattoo ink deposited?
A tattoo needle punctures the epidermis and deposits the ink directly into the dermis, the exact layer the hormones need to navigate. But a tattoo isn't just a layer of paint. When a needle hits the dermis thousands of times a minute, it causes significant microscarring.
The tissue has to heal from that trauma.
Right. And to lock the ink in place, the dermal fibroblasts engulf the heavy metal ink particles. The tissue remodels itself around the ink, creating dense, disorganized fibrotic tissue.
So the normal, highly organized tissue architecture in the dermis is permanently displaced.
Exactly. The biological road the estrogen molecules need to travel has been fundamentally destroyed. The chemical diffusion pathway is blocked by scar tissue and trapped ink deposits.
So if a patient applies their prescribed dose of estrogel over a heavily tattooed area, they will experience wildly inconsistent absorption.
The molecules cannot reach the capillary beds efficiently. The gel will just sit on the surface or get trapped in the fibrotic tissue.
And the patient won't get the correct systemic dose of their hormone therapy. It has nothing to do with the color of the ink and everything to do with the physical scar tissue buried underneath it.
It really reframes how we think about elective cosmetic procedures. I mean, a decision you make to alter your dermis in your 20s permanently changes how your physiological infrastructure can absorb critical medical treatments in your 50s and 60s.
It forces us to stop looking at the skin as just a static canvas and start respecting it as a highly complex living organ
With its own intricate plumbing and structural requirements.
in its own internal manufacturing capabilities, which actually brings us to a really provocative detail buried deep in the clinical sources.
This is my favorite part of the research.
We have covered a massive amount of ground regarding how estrogen manages the skin, but up until now, we've only talked about estrogen coming from two places: internally from the ovaries or externally from a pharmaceutical tube.
But the skin is not just a passive receiver of hormones. The skin is actually an endocrine organ in its own right.
Wait, the skin manufactures its own hormones?
It has the biological machinery to do so. The literature notes that human skin contains the full cytochrome P450 system.
Let's unpack that. What is the cytochrome P450 system?
It is a massive family of enzymes that essentially acts as the body's internal chemical processing plant. These enzymes are usually famous for breaking down drugs and toxins in the liver. But in the skin, this specific enzyme system has the ability to synthesize its own estrogen locally, directly from circulating cholesterol.
So the skin can pull cholesterol from the blood and chemically convert it into local estrogen right there in the tissue.
Yes, the local tissue can generate its own structural contractor.
If you are listening to this and thinking about the future of medicine, the implications of that are staggering. Systemic hormone replacement therapy carries risks because you are flooding the entire body with hormones.
Right, there are systemic side effects.
But what if future surgical wound care didn't require a daily systemic pill or a messy transdermal gel?
What if, instead of bringing in an outside contractor and dealing with systemic side effects, future therapies simply involved applying a catalyst that switches on the skin's own local estrogen factories right at the site of the surgical incision?
You just wake up the local manufacturing plant to flood the wound with exactly what it needs to heal the stroma, organize the collagen, and clear the inflammation.
It is a completely different paradigm for wound care. It bridges the gap between endocrinology and dermatology in a way we're only just beginning to understand.
Thank you for navigating this incredibly complex biological cascade with us. We hope this deep dive encourages you to look at your skin differently, not just as a visible barrier, but as a dynamic, hormone-driven ecosystem that requires the right structural architect to keep the entire building standing. We will see you on the next one.